We're at the IAS meeting with Joe Eron, who's from the University of North Carolina, and we appreciate you taking the time away from a busy conference. You'll be presenting very shortly. So this is embargoed for 1/2 hour, but the program that the work you're presenting is on 2 drugs being administered 4 or 8 weeks. I think I'll let you take it from there.
Sure.
For a treatment.
So this is an antiretroviral treatment, a maintenance therapy that's fully injectable. So there are 2 long-acting drugs, long-acting rilpivirine, long-acting cabotegravir. One's an NNRTI, the other's an integrase inhibitor. And the study is in previously treatment-naive participants. They go on oral therapy for 20 weeks. Those that suppress were then randomized to get these intramuscular injections either every 4 weeks, every 8 weeks, or continue on oral therapy. And I'm presenting the 96 or 2-year data that shows that a very high percentage of patients on the injectable therapy had sustained suppression. 94% on every 8-week arm and 87% on every 4-week arm.
So it's really, you're at the point where you're deciding, is it 4 or 8 weeks?
The point of deciding was actually the 48-week data, and at that time point, there were a few more blips in the every 8-week arm that actually went on to suppress. But based on the pharmacokinetics, the fact that on the every 4-week arm, there were absolutely no virologic failures, no individuals were above the 50-copy window at 48 weeks or 96 weeks. The 2 ongoing phase 3 studies are with every 4 weeks. There's a phase 3 study in development that will look at every 8 weeks for maintenance.
Because it seems to me anybody that's going to choose that treatment is not going to worry about, okay, is it every month?
Well, I don't know. That right now, these therapies have to be administered by a healthcare professional. They are not self-administered. So I think reducing the number of injections per year from 12 to 6, I think is actually a big deal if we can show that every 8 weeks is as efficacious.
Now you have to get through every single person goes on oral treatment.
Right. In the studies so far, there is an oral lead-in. The duration of that oral lead-in is being shortened over time as we get more and more experience with these drugs. In our study, it was 20 weeks because, again, it was an earlier study. The number of people who had experienced these drugs was less. So we wanted to make sure they were well tolerated before beginning the oral phase.
And also that they worked.
Absolutely.
Because if they didn't work, you're injecting the drug which is going to last.
It has a long half-life. Absolutely. Good point.
So there was some discussion about the usage of who would be best candidates, and what was rolling around in my mind was okay, I'm already on all the cardiovascular, and it doesn't matter, I'm taking pills every day. But younger people who aren't experienced as we are with taking drugs every day of our life. I know there's another guy in the audience who said he's got his pill bottle, he wants to get rid of it or something.
Right.
But it is a matter of preference, and maybe it's something for you, and you try it, and I'll go back to the pills.
Right. It's not as if you have to commit to it for the rest of your life, right? And there may be people for periods of their life they don't want to be on pills, or maybe in their life they might have more travel or have circumstances where oral therapy isn't convenient. Certainly, there are people that have adherence challenges that might benefit from directly observed therapy, and obviously it's impossible to do directly observed oral therapy for a life duration, but if something's once a month or every 2 months, certainly directly observed therapy is possible. And then the thing I hear from patients that surprised me was that people like the idea of being free from being reminded that they have HIV every day.
Yes, I know. We used to talk about taking a vacation from treatment for the summer. That was way back.
Way back, right. We don't do that anymore.
Right, not anymore. No. But it is exciting that we have these options that are coming out. And it's already treatment that's available, but it's a matter of putting it together in a way. And it is, how is the injection? Is that, it has to be administered by a clinic?
By a health professional, right? And all of ours were done in clinics and the study.
We can talk about pharmacies.
Pharmacies I think are being explored as a way. It is an intramuscular injection, so it's the every 4 weeks is 2 cc's or 2 mLs. Each shot is 2 mLs. Every 8 weeks is 3 mLs.
So it's 2 separate shots.
2 separate shots, right? Because they're 2 separate drugs,
Right.
and they can't be kind of co-formulated into one injection right now. So it's 2 separate shots.
I know we used to worry about Fusion being injected twice a day and all this. This is a lot less than
less than twice a day. And people do have injection reactions. They call them injection site reactions, but it's mostly just discomfort or pain. So it's mild or moderate pain. Things like the nodules that people experience with Fusion, well less than 10% of patients complained of a nodule. So that isn't a common problem. It's mostly discomfort. It's interesting with the first injection, almost 80% of people experience some level of pain, usually mild, but had some level. But actually, the proportion of patients that complained of an injection site reaction diminished over time. And I don't know who was more nervous with that first injection, the patient or the person doing the injection.
They stiffened up and maybe
that may have had something to do with it. But it's really quite dramatic. It went from 80% to 30%.
Wow. So if the person chose to get off of the treatment, then how would they do that?
Well, I think that there is a tail on the therapy. What we've done in people who have decided to switch off or had to move away from a study site is just go directly onto oral therapy. Obviously they could, cabotegravir isn't available orally, but they could go on rilpivirine dolutegravir, for example, if that was their choice. That's been now shown to be effective as maintenance therapy in the very large SWORD studies that were presented at CROI. So that would be one alternative. But basically, when the person decides they no longer want to be on injectable, they should go right onto oral therapy.
So it wouldn't be a problem having maybe too much medicine on board.
No, I don't think so. I mean, again, the safety margin for cabotegravir or dolutegravir is quite high, and so I don't think that's an issue.
So moving forward, what is the next steps?
Well, the next step are completing the 2 phase 3 studies that are fully enrolled, and we have to wait for 48-week data. And then those studies will then be presented to the regulatory bodies in Europe and US and other places. And that's really the next step.
So it could be commercially available.
I think it's at least a year.
That'll pass in no time. So
yeah, it passes.
Stay tuned.
Quickly.
We might have an injectable here. That'd be fabulous.
All right, great. Well, thank you very much.
Thank you very much.
It was really fun.
Appreciate it. Yep.
All right, thank you.